Hello, everyone. This is Dr. Janine Cross, and this video is a brief overview of child maltreatment um, with NICU populations, and that is an abbreviation or acronym for Newborn Intensive Care Unit. This presentation is titled "When NICU Children Aren't Safe at Home." The objectives of this presentation is to review current child maltreatment findings, understand factors, risks, and costs associated with child maltreatment, outline child maltreatment interventions, and discuss the implications for social work practice in NICU, in the newborn intensive care. It also seeks to present new research to prevent NICU child maltreatment specifically. So we start off talking broadly about child maltreatment, and then take a more focused view on what it looks like with children from the newborn intensive care. A copy of this PowerPoint will be listed in the PowerPoint folder. This is an updated link to a video called End It Now, Understanding and Preventing Child Abuse. This video goes into detail about how child abuse impacts people later in adult life and some of the risk factors for adults who have been abused as children. Also talks about the ACEs study, the Adverse Child Event study. So please take your time and watch that video. It's very helpful in getting a better understanding on the long-term impacts and costs, emotional, mental impacts, family, societal costs of child abuse. So again, please make sure you click on that video. Um, what do we know about child maltreatment? It is considered a public health concern. And why? When we think about public health concerns, for an example, COVID-19 is a public health concern. It's considered a pandemic, but also one of the most largest public health concerns of our time. But child abuse also is because of its long-term outcomes and effect of the society in terms of cost, and it's systemic. So we see that issues, emotional, physical health issues, find themselves from survivors of child abuse well into their adulthood. And so, what are some of the adverse outcomes of child maltreatment? People that we know that have been impacted by child maltreatment have physical health concerns. They tend to have lower life expectancy. They tend to engage in behaviors that are not promotive of healthy healthy living. And so we find that they tend to have more physical health risk than others. Also, you'll know in that video that you're going to watch, it talks about how um, people who suffer from ACEs have higher risk of chronic illness, chronic disease, and ultimately lower life expectancy. So we do know that the adverse outcomes related specifically to child maltreatment does include physical health issues for survivors. Also, we know that people who survive child maltreatment also develop maladaptive patterns, whether it's within their interpersonal relationships, but maladaptive patterns that reduces their quality of life and functioning. We also know that survivors of child abuse also engage in risky behaviors. This can be drinking, substance use, and in addition, their interpersonal behaviors or interpersonal relationships are also unhealthy. We also know that violence and delinquency rates are higher amongst people who have been abused as children, and also mental health concerns. A lot of people who have been diagnosed, or I'm sorry, who have suffered from child maltreatment have diagnoses of depression, anxiety, definitely PTSD related to some of those experiences. And also, there's this concept of cumulative trauma, in that people who have child maltreatment histories also have a pattern history of traumatic experiences after that. And this could be related to maladaptive, risky behaviors, violence and delinquency, and or mental health. But there's also this cumulative trauma. And when we think about cumulative trauma, think about higher risk for multiple events of traumatic experience happening in someone's life. The estimated cost of child maltreatment on society is totaled at $80 billion. Again, when you think about the health risk and treatment, juvenile justice and or returning citizens programs, you think about incarceration rates, all those things, physical health issues, early morbidity outcomes, treatment, um, doctors, therapists, all that goes involved, child maltreatment, child welfare services, the cost to society to manage and deal with child maltreatment ultimately ends up being this figure here at $80 billion. Um, what you'll find in the Department of Health and Human Services, the child maltreatment rates do not change much over time. Even though this is 2012 statistics, even the most recent 2015, I think 2017 was the last statistics that I see, the breakdowns related to the types of maltreatment are pretty similar. Neglect makes up about 75% of all common child maltreatment types, with physical maltreatment being 15% and sexual being 10%. So here, most of the child maltreatment reports that are filed and are investigated and substantiated tend to be neglect in nature. Again, 15% physical, 10% sexual. So who are those people filing those child maltreatment reports? So we know that about 59% of people, professionals reporting child maltreatment tend to be law enforcement officers, education and social services. So out of the 60% of professionals that file maltreatment reports, the three main areas, 60% of them is law enforcement, education, and social services. And when you look at the breakdown into the numbers, it is listed here by the amount. So out of that 60%, law enforcement officials file the most amount of reports, followed by professionals in the education sector, then social services. Then we know that non-professionals make up about 18% of total child maltreatment reports. This means your regular everyday citizens, friends, neighbors, and relatives. And then there are unclassified amount. Okay, so that unclassified amount that makes up about another 20% of all other child maltreatment reports are people who are anonymous, who file reports as anonymous or what is actually classified as other. And so here, we want you to know that, or at least I want you to know that professionals make up most of the child maltreatment reports, but not just professionals. We also rely almost about another 40% on non-professionals and anonymous calls for child maltreatment investigations. Um, what do we know? Again, 59% are made from professionals, but we also know that there's been a gradual increase in child maltreatment reports over time. And why is this the case? We know that we've improved and modified the definitions of abuse, and once you are more clear on what those definitions of abuse are, and operationalize, what those definitions are, professionals and non-professionals are able to identify it and report better. We also have improved enhanced reporting measures and tools to help better efficiently report abuse. We also have improved identification by practitioners and mandated reporters. Oftentimes, mandated reporters and practitioners engage in child maltreatment or child abuse professional development training, either through their jobs or through professional organizations. And through those trainings, they're able to better identify and report uh, child maltreatment. And another area is media scrutiny. We do know that oftentimes some of the most egregious child welfare, child maltreatment cases finds its way through the news sources and news media, and so through that increased knowledge and awareness through media scrutiny, people are more aware of child maltreatment today and are able to make appropriate reports. However, there's some other things that you also need to know about child maltreatment reports. An overwhelming amount are underreported. So we only know the statistics provided only provide information on those reports that are made. We don't know the full scope, and our understanding is still limited in terms of child maltreatment reports overall because we know a lot of times underreporting occurs. We do not know about all the child maltreatment incidents that occur in the country. Well, we know that more than 50% of violent crimes for youth are unreported. We also know that there are specific factors of underreporting. And so, again, we know that easily more than 50% of crimes um, for youth go underreported. So we know that the numbers that we have are probably higher than what we imagine. Factors for underreporting include denial. Think about an abused child that's dealing with emotional ramifications and mental ramification of being abused. Oftentimes they deny. They don't want to accept what is happening to them, and so that does not help them get the support that they need because they deny that it's happening to them. Oftentimes, the trauma related to child maltreatment results in failure to recall. Also, because oftentimes children don't have um, the advanced, sophisticated cognitive abilities as adults. Sometimes they misinterpret or misunderstand what it is that is happening to them. Or sometimes because of mental emotional challenges related to the abuse, it may also play a role in their misinterpreting of the events. There's an embarrassment and shame associated with being abused physically, emotionally, or neglectfully. And so that embarrassment may also lead children to not report. Also, there is a phenomenon known as betrayal trauma, and this is where a child is unwilling to report abuse by someone that is close to them. Oftentimes, child abuse occurs through family members, friends, adults that the child is close to and trusts. And the reason being is usually those are the people who are able to exploit that closeness or exploit that relationship in order to um, perpetrate the abuse experienced by these children. And so we know that there are also specific child risk factors, and some of the risk factors that are associated with child maltreatment specifically is infants. That we know that infants who are 18 months of age and younger are at highest risk for being abused. We know that health factors such as prematurity, twinship also increases risk factors, um, and hyperactivity. So behavioral manifestations of hyperactivity also increases. So these factors are highlighted in red because these are some of the highest risk factors that we see. So infants, particularly under 18 months of age, are at highest risk. Infants that are premature, infants that are twins, and hyperactivity in general in children tend to increase risk factors for child maltreatment. Mothers, young maternal age can increase the risk factors for child maltreatment. Other factors include poverty, low education, mental health issues related to the parent or child, parental substance use, history of domestic violence in the family, a lack of family and social support, and parent perpetrator as former maltreatment victim. And so when we have parents who were former victims of maltreatment, that increases the chance that they may that poses a risk factor for them engaging in maltreatment of their own children. So again, these are some of the risk factors that we know. When you see these risk factors in your work with clients, you know that um, taken in its totality, it may increase the chances of child maltreatment. So what do we know specifically about the victims of child maltreatment? Again, children who are under the 1 year of age and older have the highest victimization rate at about 22% per 1,000 children. They're also the highest group that has the highest victimization rate in the nation. They're also the highest fatality group. So their children under the age of 1 have the highest risk of dying from that abuse as well. And there's an increase in child welfare investigations in other countries. So we also know that infants also have higher rates of child welfare investigation when it comes to other countries as well. This graph here, again, this doesn't change too much over time, even though this is a 2012 graph, but if you look at the 2015 to 2017 rates, it looks very similar. So here you see the victimization rate, 21.9% for children at birth. And then as the child gets older, you see their victimization rates decrease. And this is not surprising, as the more vulnerable the child becomes, the more higher their victimization rate. But as they start to get older, up until the age of 17, that rate decreases. Child fatalities in 2012, about 1,640 abuse of deaths, 1,640 abuse deaths occur. So this is about 1,700 children die from abuse. 2.2 deaths per 100,000 is the national rate, and we know that 70% of these 17,000 children were 3 years of age and younger. So how do we address child maltreatment, particularly in a NICU environment? So up until now, you're starting to learn and understand a little bit more about the severity and seriousness of child maltreatment and why it's a public health issue. You're also starting to get a sense that infants are our highest risk group, and when you think about mental health needs of, the physical health status of that infant, that increases the risk, or any child. But also, when you think about those other factors such as substance abuse, domestic violence, you start to get an understanding of what are some of the things that lead to child maltreatment. Now, understanding those risk factors and understanding those high fatality and those high risk groups also starts to help you understand how to go about treating maltreatment, particularly in a NICU environment. And so, what in a NICU environment, social workers need to be very aware that of the risk factors for child maltreatment and understand those risk factors when a child is delivered in a newborn intensive care. So, if a social worker wants to think about what child in a newborn intensive care is at high risk for child maltreatment, you want to look at those newborns that are called substance exposed newborns. These are um, newborns that are born where either the mom's toxicology result is positive or the baby's toxicology result is positive for either marijuana, cocaine, crack, or any substance use, illicit, legal and illegal. Parents are unable to provide needed medical care, right? You also want to look at the parent's ability to provide care for that baby, medical care. And so issues such as poverty can impact a parent's ability to provide the needed medical care. Mental health status of the child, or the parent. You also want to think about the education and the support resources. So when you're working with the family, you're looking at poverty, mental health, you're looking at their educational level and their support resources, because all these things may help you understand if there are risk factors there for child maltreatment. You also may see behaviors of parents where they're not making medical decisions that are in the best interest of the child. That's usually a risk for child maltreatment. Um, and sometimes this can be hard for a social worker to ascertain risk in terms of child maltreatment, but that's because of oftentimes there are unclear definitions of abuse and neglect. We have gotten better about our definitions, improving our definitions of abuse and neglect, but there are some states that still need to work on improving those definitions so that it's more clear what it is you're reporting, particularly related to a baby who may be already medically fragile. So, who to serve? When you're thinking about child maltreatment, you're looking at caregivers. 81% of neglect perpetrators are parents, with 37% being mothers and 19% fathers. More than half of abuse and neglect perpetrators are women, and most fatal neglect perpetrators are female and biologically related to the child. So, um, mothers, a lot of the interventions and focus should focus on the entire family, but targeted interventions and support for parents and particularly mothers. So, caregiver risk factors. So, some of the risk factors related specifically to parent. We talked earlier about child risk factors, but parental risk factors or caregiver risk factors includes mothers or parents with traumatic histories or trauma histories. Think about caregivers who have difficulty forming healthy interpersonal relationships. Think about specifically the postpartum period. The postpartum period, children are at the highest risk. That's that period between birth to 12 months. And remember the risk factors on the prior slide where it says children up to 18 months and children that are 1 year of age and younger are at highest risk. So that will be considered the postpartum period. And also, trauma undermines parental intuition and sensitivity. And so, if it's a parent that already has a trauma history, their ability to attune and attach to their child is compromised often. Also, if the trauma related specifically to the NICU admission, when a baby is admitted into the newborn intensive care, it is a traumatic experience to see your child delivered and put in on breathing tubes, and oftentimes uh, have an increased chance of not surviving a NICU admission, and so that is traumatic. Oftentimes, the birth and the circumstances that surrounds the birth itself is traumatic for the mother as well. So, traumatic birth experience or birthing experience plus a traumatic NICU experience, and if that mother already has a traumatic history of trauma, that will increase the risk factors for child maltreatment as well. And so this slide just talks about, the neurodevelopmental influences and how trauma impacts neurodevelopment. So traumatic experience have a direct impact on neurodevelopment. And we also know that a lot of times neurodevelopmental challenges also lead into psychiatric disorders. Supplemental risk factors, cultural considerations. When you think about child maltreatment, think about they have to be considered in context of culture, lower and other type of risk factors. So understanding the cultural backgrounds of clients and any type of challenges related or understanding or misunderstandings related to parenting that is a direct um, um, link to cultural beliefs, behaviors, and values needs to be looked at more closely. Again, lower education levels, particularly comprehension levels, math, reading level skills of parents are supplemental risk factors. Reduced skills, so time management, care coordination. When parents have reduced skills related to parenting, this increases the risk for child maltreatment. Also, medical teams' expectations also are risk factors. Sometimes medical teams provide or discharge a medically fragile child to a parent, misunderstanding their ability to care for that medically needy child. If a parent struggles with caring for a medically needy child specifically, that may lead to aggravation, frustration, irritability, lack of sleep, and this combination increases the risk of child maltreatment as well. Poverty exacerbates parents' ability to provide follow-up care, such as transportation, utilities. So think about a parent who um, is unable to pay for medication for their child, unable to keep basic necessities um, for that child to grow and thrive at home, good nutrition, um, heat, for instance, and so forth. And sometimes there may be key follow-up appointments that keep that baby healthy, and that mother or caregiver is unable to make it to appointments or miss important appointments because of transportation issues. Oftentimes, multiple siblings in the home stress stretches that parent very thin in terms of their ability to care for that medically needy child. And sometimes, when a mother has a medically needy, fragile child, like a NICU infant that is discharged, they're at high risk of having other special needs children already in the home. And again, if there is just a special needs child in the home, that may also increase the stress on that parent and also resulting in higher risk for child maltreatment. We also need to look at mental health concerns, depression, specifically postpartum depression, and PTSD, because those are also risk factors for child maltreatment. Now, there are specific NICU related child risk factors, right? So just having a child in a NICU itself is a risk factor. Those children have special medical needs and they're oftentimes challenging to care for because of those medical needs. And so their care burdens can be higher than a healthy infant. They may have specific unique needs that need to be addressed related to bonding, putting on weight, and their specialized care and follow-up care. Sometimes multiple medications, a lot of follow-up appointment, a lot of early intervention services, and other development follow-up. There's also concerns for developmental delays related to children who are in a NICU who may be of low birth weight. But if that baby or that infant or child has a developmental delays and parents have expectations that are not consistent with where they are developmentally, that can also lead to frustration of that child and increased risk for maltreatment. How that parent deals with loss and fear of loss of a healthy child, a loss of a normalized pregnancy. There's a lot of losses that happens when a mother delivers a baby in a newborn intensive care, and so that loss and how that mother is able to cope or not cope can add to the risk factors of child maltreatment. Um, Oftentimes, children in the NICU are in isolate. They also have breathing tubes, and there's some days that are good to bond, and some days if the baby's not having a good day health-wise, it's not a good. Mothers can't bond, and so that impaired attachment and bonding increases child maltreatment. And that and oftentimes having a baby in the NICU for sometimes several months at a time, 3, 4, even 5 months or more, um, that parent is not able to engage in normal parenting functions. And so they're unable to not only establish those attachment bond, but there are learning opportunities for parenting, understanding your child's cues, learning how to feed, and also with the baby being premature, their care needs are different. So parenting functions look different for premature infants. Oftentimes, because the baby has to put on weight and has to get to a healthy place before the mother can fully engage in most of the parenting functions, giving a bottle, bathing the baby, taking a temperature, and so forth. Um, the the parenting skills can feel diminished to that parent, and so they're struggling with understanding and addressing their baby's needs, and that again adds to frustration and increases the risk. And also, there's this unknown with NICU infants, unknown medical trajectories post discharge and complications that may occur. These children may have developmental delays, they may have behavioral challenges as they get older. They may even have severe neurodevelopmental challenges that may require full care. And so, because oftentimes we're discharging infants and that medical trajectory is unclear, that may also add to the mental health and emotional challenges risk to babies as well. So, what is it to address as a social worker? You want to look at a parent's ability to manage their impulses as they care for their infants. Again, dealing with caring and parenting a medically fragile child is stressful. It's hard. It's very challenging on parents, and so you want to be able to assess how well that parent manages their impulses. You also want to assess environmental stresses such as poverty, trauma, and the NICU itself. That means connecting those parents to resources so that they have food security, financial support. Sometimes there's social security, disability benefits to help with the financial income in the home for that NICU child. You want to address any trauma, get that client or that mother or caregiver into any type of outpatient mental health or inpatient mental health treatment to address the trauma that has occurred either prior in their earlier life or trauma related specifically to the delivery and birth of the baby and the newborn intensive care environment. You want to at least give the parents time to acclimate to that environment and give them the support that they need to cope and get through a NICU stay. Resistance and history of trauma is an issue. Again, you want to pay close attention to that. And if a mother or caregiver is resistant to seeking help or getting the support that they need, that may mitigate or reduce the risk factors. Also, cultural considerations. You want to make sure that there are no cultural barriers to understanding the care needed and making sure that client or that patient is fully supported with their infants. Child welfare versus child protection. And so you just want to, really um, be clear here. Oftentimes, child maltreatment is very um, reactive, and that oftentimes child maltreatment isn't addressed until after it has occurred. What we need to do is more focus on child protection, making sure we children remain safe. We put the supports in place to deal with poverty, trauma in the NICU environment. any of the risk factors, being proactive to address the risk factors before child maltreatment occurs. And so, what are some of the evidence based interventions and models that help us with child maltreatment? Home visiting services, early interventions, are additional support services that can be provided to parents in their own home. Increased parenting education, okay? Education related to abusive head trauma, and its effects and impacts on infants and children. Talk therapy, motivational interviewing, are also evidence based interventions that improve outcomes for parents, particularly child parents who have been found guilty as perpetrators of child maltreatment. Another evidence-based intervention program is the Triple P Positive Parenting Program, which is a evidence-based parenting coaching and support model. The graded care profile, the multi-factor offender readiness model, peer support mentorship models, and parent-child interactive therapy, PCIT, and art therapy. You can take your time and learn more about these interventions, but these are just some of the evidence-based interventions that we know work very well with addressing and improving outcomes for parents who have been perpetrators of child. Some of the protective factors we want to think about with child maltreatment is improving attachment bonds and mental health for parents and caregivers. So helping parents develop secure attachment bonds with their infant and children, and making sure that they are mentally well, or engage in wellness, or if they need to see therapists to help them stay mentally well, that's in place. You also want to make sure that by making sure that those attachments are good and that are secure and that mental health is good, it tends to activate a regulatory system and promote social bonds and further improves the brain development specifically for the infant. And so, what can social workers do? What can perinatal social workers do specifically? Perinatal social workers are specialty social workers that work in maternal child health, particularly infants who are 1 year of life and younger. Hospital-based services. We want to make sure we try to focus healthcare back into the home. So home visiting services as much as possible with providers to support that mother and that baby that was discharged from the NICU. Child abuse pediatrics is a particular specialty where the pediatrician is a point of intervention and prevention. And so oftentimes when you're dealing with a medically fragile child, it's hard to tell if there are any injuries or medical setbacks for that child, if it's related to their physical health status or if there may be child abuse going on. So child abuse of pediatrics help determine whether injuries or health challenges of a child is more related to their diagnosis or whether it's related specifically to child abuse. There are also protocols in place such as the Hague Protocol and the Hospital Child Protection Programs. And these protocols tend to be first line defense where they're trying to catch perpetrators through ER visits, doing more screenings, and asking more questions to try to see if there's any risk factors that may lead to child abuse. So what are the implications for perinatal social workers specifically? Historically, social workers have the skills and knowledge as providers of child protection services. Historically, social workers have been providing healthcare services for centuries. I'll go a step further and say maternal child health is one of the earliest healthcare areas in which social workers have impacted. Perinatal social workers are well positioned to serve high risk and fatality groups because they're in those settings and they can do those assessments of risk and put the interventions in place that are needed to improve outcomes. And so, social workers, and particularly perinatal social workers, are the answer to the public health crisis of child maltreatment. Also, perinatal social workers must leverage social service knowledge and healthcare knowledge to improve outcomes for these vulnerable parents and families. Implications for perinatal social worker. Again, we need to lead child maltreatment prevention services inside and outside the hospital. We also need to broker trauma treatment services for mothers and families, advocate for attachment-based policies, procedures, and protocols in healthcare settings, and promote relationship building in the mother-infant dyad, such as kangaroo care, breastfeeding, and bonding. Research implications, breastfeeding is a bonding tool that helps improve bonds for mother and infant. It's also a parenting skill that can be taught to mother at the very early start. And so this bonding helps improve outcomes, health outcomes. Breastfeeding helps improve health outcomes for infants, but it also improves mental health outcomes for moms and includes bonding for moms. And it also teaches them to understand, learn their babies, and also be able to respond to infant cues. So breastfeeding is a good intervention tool. And more research needs to explore breastfeeding as a protective factor for for child maltreatment specifically. Some of the theoretical frameworks to consider when we're thinking about attachment and improving attachment, and breastfeeding particularly as a tool to improve outcomes, is Bowlby's attachment theory. And the attachment theory says organisms have attachment systems, and organisms are protected by close proximity of caregivers. And that attachment system is developed between the first 6 to 12 months of life for infants and the caregiver. And secure attachments are categorized as attachments are categorized as either secure or insecure. This is the attachment theory. And so, if you understand attachment theory and apply that to child maltreatment in the NICU environment, it would suggest that by improving attachment bonds, by keeping close proximity of the caregiver to the child, that will improve overall outcomes for children. Also, empathy is developed through parents of their child and their needs. The caregiver is able to exercise warmth, compassion, sympathy, and understanding for their infant. And then that dyadic symptom, the mother-infant dyadic system is better self-regulated. And again, the mother is able to understand the empathic responses of their infants, and they're able to parent better. So breastfeeding promotes attachment and bonding. Breastfeeding teaches parents to properly read and respond to the infant cues, and it increases parental involvement and improves confidence in that parent's ability to parent that child. Again, this presentation was a quick overview of child maltreatment in the NICU environment and how social workers can improve outcomes for this public health concern. Thank you.